Good afternoon, everybody. This is Mark Lynn with Healthcare Business Specialists in Chattanooga, Tennessee. We'd like to welcome you to the conducting an RHC inspection webinar with Kate Hill from the compliance team. This is my contact information if you need to get a hold of me. Danny Gilbert is here as well. She will be manning the questions and be helping us out with technical issues that we may run across as we go through here. And if you're not a member of our RHC information group, please join. We have over 3,000 members. We have this newfangled scan code here that if you scan it, you'll go right to it apparently. So that's something brand new. And our website is ruralhealthclinic.com. This is where you're going to find your presentation materials. There will be a recording of this session. So if you've got people that need to watch this later on, we'll record it, put it on YouTube, put it on our website. And there are 4 handouts over in the sidebar over here where it says handouts. There's the presentation. There's something from the NARHC on the vaccine mandate, the policies and procedures there in Word format. There's Kate's presentation as well. My administrative presentation is on there with links that work. Hopefully it will download. Sometimes GoToWebinar doesn't play nice with us and doesn't let you download that. But we have put the slides in the group, the RHC Information Exchange group, and it is on our website right now as well. So if you want to get your hands on the slides as we go through this. Just a reminder, we are having another webinar next week on Medicare cost reporting. It's not as exciting as what Kate's going to talk to you about today, but it is something important, and there are some deadlines that you have to do. If you're going to write off bad debt, write off your bad debts now and put that schedule together before year end if you're a 12/31 year end. That's the big reminder that we have. And we do have a sponsor. We're thankful to Azalea Health. Matt Mayfield is here, and we want to give him a minute or two just to say something about Azalea Health and how they can help you run your rural health clinic. So Matt, take it away.
Thank you, Mark. Appreciate the introduction. We're happy to be a sponsor of your organization and a longtime partner of Mark and support everything that you do. Like Mark said, we are, my name is Matt. I'm a sales executive here for Azalea Health. We are a cloud-based medical software solution company based here in Georgia. We were founded actually in 2008 in a small town in South Georgia. And really, since our mission, we've gone out and really tried to help the underserved healthcare communities improve patient care and profitability in a number of different ways. And I think that really starts with our user-friendly and innovative EHR solution. It's a fantastic system that many rural health clinics use across the country. And you can see there we have over 100 different RHC partners now. In addition to that, we also offer revenue cycle management services. And part of that, and part of why we're successful with RHCs, is we have a team made up of about 75 certified billers who have a lot of experience with the nuances that rural health clinics have when it comes to billing. So really, when I'm going out in the field, I'm meeting with RHCs, and probably I've met with some of you on the call, and hope to meet with many more of you. We're really trying to learn about some of the inefficiencies and frustrations you have when it comes to your EHR software. I know sometimes that's a touchy subject. We really want that to be the last thing that you think about when you're coming into the practice every day, especially as your focus should be on patient care. So love to have conversations with any of you that might be having any issues with your software, your billing efficiencies, just to see where we could be a solution as we wrap up 2021 and head into 2022. So you'll see I have my contact information listed there. Mark also has my contact info if you want to reach out to him if you don't get a chance to get it from this slide here. But thanks again, Mark, for letting me chat with you guys for just a few minutes. Wish everyone the best as we close out 2021 and move into the new year.
Thank you, Matt. I really do appreciate that. And if you do have things that you want in your computer system, in your billing system, sort of your Christmas wish, you wish your electronic health records did this, you wish your revenue management did that, email me this. I'm actually Matt and his team, the Douglas Wards and the executives. We're going to have a little meeting next week, and we're going to talk about things to improve Azalea and their systems that they have. So email that to me, and I will pass it on next week when I'm meeting with the executive team over there with Azalea, and just to give you a better product for you guys, and that we already got a great product, but we want to have an even better product. So that will be great. Moving on to our speaker.
Oh, where did you get that?
Yep. I'm about ready to switch it over to you here, Kate, but Kate Hill, registered nurse from the compliance team. I think everybody knows by now about Kate. I wanted to put you in there because it reminds me that, you know, you are a war hero. You've served in Vietnam. My father actually served in Vietnam as well. So, you know, we're very thankful to you for your service. I call you a miracle worker because you really, for Rural Health Clinics, you've worked miracles. For me, I think I've had a couple Christmas miracles that you've given to some of our RHCs by doing surveys at the last second before bad things started happening. So we appreciate that. You've been a great friend to the RHC community, and so we thank you for all of your amazing service, and we thank you for giving this presentation today. I am going to make you. Let's see here. I'm going to make you the presenter. And if you don't get that one, let me know because you showed up. There you go. There we go. It's working great. All right, Kate, it's all up to you.
I have to say something about that. First of all, that was a shocker, and thank you for that. I'm no hero. The heroes were the men who served. We were nurses. We took care of them. We were no hero here. No hero here. At any rate, you make me cry on that one.
Oh.
It tells you how old I am, and there was a waist there. What an exciting thing that was to see. Let's get going here. Okay. I got to work on that. Learn how to do a mock survey yourself, and that way you stay compliant, waiting for those inspectors to show up. Understand the common deficiencies, and we'll touch a little bit on the Appendix Z update and a little tiny bit on the new 491.8, which is now on hold, but we'll hit that for just a second. So you know right now that the PHE is extended to at least January 22, and the secretary had said he would give us a 60-day notice when it's going to end, and we didn't get one, and we're within 60 days of January, so that tells me we're probably rolling to April. They're only allowed to write it every 90 days, so that's why you can't know that ahead of time, but since he said that, I'm thinking we're rolling to April, and of course there's no surprise there to any of you on that one. So this is where the rules are. When you want to know exactly what the law says, you go, the best is to Google 42 CFR 491.6 or whatever, pick one. And the first one that pops is Cornell. And that is a great site. It's very simple. And there are toggle switches between all the 1 through 4s. Yes? Hello? No, somebody needs to mute that's not muted, please. Okay, so here's what we're going to talk about today. We want you to conduct your own mock survey. Use the checklist. Hold a kickoff conference with the staff. Listen, surveying, compliance is not a one-person sport. It is a team sport. And the more eyes you have in the clinic with knowing exactly what's expected, the better it'll go. And you'll stay compliant and stay, if you will, company ready all the time, so that any surveyor from the compliance team or the state can walk in the door and you're good to go. You want to do a walkthrough with your checklist in hand, and I should add there, and a red pen. So where you see an issue, circle it, check no or whatever, and then we know what to fix. So can you answer yes to all the questions? And then you have to have some areas that need some more concern, some more attention. Then sit down with your policy book and make sure you have all the policies. Some of them I know you can get rid of. Some of you have policy binders that are 6 inches thick. You need to have what you need to have. Of course, they're your policies, but try to simplify it. It's hard to keep up with all that. But not only do you have the policy that you need, do they have all the elements that are contained in the checklist? Take something like the drug policy. There's a lot of elements to a good drug policy. Do you have them all? Are you following your hospital policies? And you can. It would be very unusual for a provider-based RHC to not follow the hiring, training, orienting policies of their hospital. Just make sure you're named in that. So the hospital policy includes all entities owned by that hospital, something like that, a statement like that, unless the names of the actual clinics are there. And interview the staff to ensure they're knowledgeable about the policies, the procedures, their job responsibilities. Nobody knows the answer to every question. They need to know where to go to look. Okay, let me say this. If you're manager and you're listening, share your information with your staff. Let them know where everything is. There's nothing worse than a tough survey day where the staff doesn't know where to find things because you just happen to be off that day that we show up, because they're always unannounced, right? So it's really a good idea to share that wealth. And then finish with a wrap-up conference and celebrate their successes. They've worked hard. Now's their time to shine. Set the tone. And it's an open book test. Every reg that you're going to be measured against is in the books. There's no surprises here. And make sure you can answer yes to everything. And then enthusiasm, not apprehension. If they're comfortable with it, there's no reason to be apprehensive. Okay. We hope you'll have a fair survey no matter who does it. We work really hard at that. We train every month to make sure it stays that way. But glitches happen. And so we hope that you don't have one of those. There's the checklist. You got to have one because that's how you're going to keep yourself on track. And that's a good way to do your mock survey. Okay. So you're going to start at your front door. Does the sign match what we told CMS our name was? You'd be amazed how often that isn't the case. So your name is important because that's how you represented yourself to CMS. You have your billing number and your name. So you have to go into Paycos and update it if you change your name. And you do that. So we know because we drive up and that clinic technically isn't even there. It's a name problem. Never move. Now this is a little extra piece here. Don't move until you check with your state office of rural health, have somebody run that HIPAA, make sure. CMS makes the final determination, but you don't want to move because that area grew up around you and now you're not in HIPAA anymore. You're grandfathered in the building you're in right now. And so you're going to not lose your status, but we don't want you to lose it because you moved next door. Name changes, as I said, report to CMS. The medical director is a reportable event. That's where the buck stops in a rural health clinic. So the state needs to know that. That does not go to CMS. It goes to the state on a CMS 29. And of course, if you're an accredited clinic, it goes to your accreditor. And then any other changes on your 855. Walk in your door. Can a patient get in that door? Now we're exempt from ADA, but we have to have a clinic that our patients can get in the door. Can they comfortably get in your door? Are your hours posted? Are they accurate? Right now we're seeing changes. You can post a piece of paper on the window because we have temporary changes because we're all having staff that's ill and staff shortages and whatnot. Make sure we have that posted on the door, the hours. Your waiting room, what does it look like? Now, the one on the right during COVID, I would be very unhappy about that because there's too much to clean there. But that's obviously a pediatrician's office. And so we want to make sure that we have less in there right now. It's just necessary. How many times a day are we cleaning as it is? And that's just a whole lot to clean. The one on the left, I like that picture for one reason. If I'm sitting in that chair as a surveyor, I'm listening to that person with that window open, calling labs and whatnot. We have a HIPAA violation. She calls up Kate Hill and says, hey, the results of your labs are thus and so. That's not good. You can do it with the window closed or somewhere else in the building, but you're not there. So that's important as well. I could spend an hour on the exam room. You're going to look at all the equipment, make sure we've got it inspected if it needs inspection. Ophthalmoscopes, otoscopes need batteries and light bulbs. They don't need to pay for that. We're going to ask the wet time of the disinfectant used on that table because we want to make sure we're killing the bugs we're supposed to be killing. So if it's a 3-minute wet time, you don't wipe it and pull the paper down. You go wipe it and go out and get a patient, pull the paper down when you come back. We're going to make sure there's no chemicals in that drawer underneath for pap smear specifically. That is formaldehyde, does not have to be locked, but we want it above counter level so that we can be sure that no child is going to get into that while mom's on that table. Number of things in the exam room that need to be secured, and we'll hit those in a minute. The patient bathroom should have no chemicals under that sink. For sure. You can have TP there and some other things, of course, but not that. The staff bathroom, all bets are off. It's your bathroom. Now, the sharps containers need to be locked and mounted on the wall. The one on the left is not acceptable. We don't want to help someone that's got a problem, want to reach in there and grab some dirty needles. We're not going to help them out. They need different kind of help than that. And so we're going to make sure we have the proper sharps containers. Biohazard containers, if you have them, the red bags it's covered and it's stickered. You do not have to have, there's no law that says you have to have a red bag container. We think you should have a couple red bags. And so grab it if you've got bloody, dripping dressings. Red bags are not for Band-Aids. They're for drippy, bloody dressings. And then you dispose of them properly with a service. Oxygen. Now, to provide emergency service, we think that a rural health clinic should have at least one tank. Not all states require that, certainly. And if you have, if you're with us, you have one tank and it's chained or in an approved cart, as yours should be. If you have more than one tank, we're going to separate full from empty. So we never want to grab an empty in an emergency. And we're going to have the tubing and the mask or whatever we have nearby so that we can grab it and run along with our emergency box. Now you're ordering the 2022 posters for your clinic. This is for the staff. And you'll order your state, of course. State and federal posters are required in a place that's visible to the staff. It's the hiring, the wage, and the OSHA poster. Provider-based clinics need to have it in the clinic. A clinic is an entity of its own, and you need to have your own posters. And I mentioned the equipment before. All the equipment is on your list. You've got a master list. The only way you know what needs preventive maintenance inspections is by the manufacturer's instructions for use. And if you don't know, we're gonna look at that together and see if we should have had a sticker on something. An EKG unit always needs that. And I've not seen that for an AED. They do have a battery checker and the pads expire, so you want to remember that. So once a year, it all gets inspected. Save yourself a citation. If something's broken and it didn't get inspected, you can save a citation with a Post-it note. Post that it's broken, waiting repair, and we're all good. But we're now not going to use that piece of equipment for a patient. So keep your eyes out on all that equipment. Now, on this slide, let me move this out of the way here. All chemicals, all biohazards, all sharps, and all medications are secured within the clinic. Again, this is for your safety, your patient's safety, the children, anybody that wants to get into something, into trouble. And that can be a key, it can be a swipe, it can be a lock, whatever you do, but they're secured and they're away from inquiring patients, and they are out there. Now your HR file should be complete. You have an application, I-9s, W-4 for the one person that has to be employed. All the rest could be contracted. Your OIG exclusion list, signed job descriptions. Everybody needs, how can you evaluate people if they don't know what their job is? Your standards of conduct, performance evaluations, once a year at a minimum, annual training. What are you training on every year and how do you document that? How do you show that to a surveyor that we've done our annual training? Competencies, any new procedures and processes you're doing. How do we know how to do it? Background checks. I will say something on background checks. Of course, it's good process, right, to do background checks. But if you put it in your policy, then it's going to be required that you live by your policy. The surveyor can survey to your policy. So if your policy says background checks are completed on every new hire, then we're going to look for it on every new hire, okay? Otherwise, it's by state law. Again, it's good practice. TB screening on hire. Just this week, I heard a lecture, it was Louisiana Rural Health meeting, and they had a lecture on the increase in TB. Don't forget about this. So with all the rest of it going on, you should, on a new hire, you should test for TB. Beyond that, it's just screening annually, but you should definitely still be testing for that. We have a lot of rural areas with a lot of migrant workers, and there's a fair amount of TB there. Now, Hep B for everybody that works directly with the patient. So your front desk, your billers don't need it, and they can sign a declination. And that happens often when we've had the series long ago and we can't find that proof, but we know we're safe. So they just sign a declination. And so there's a good chart to use for your HR file check. Especially if you're independent, it's a little hard to keep up with that when you're an independent. When you're a provider-based clinic, of course, we have staff at a hospital that does that for us, which makes it nice. Don't forget. Yes?
Really quick, a question came in and they asked, is the TB testing upon hire required or suggested?
It's required by the compliance team. And beyond that, it's by state. So I'm pretty sure Louisiana, California, maybe Texas required annually. So you'd have to check with your state. And that's, of course, where there's rates of TB. Good question. So if you're with us, it is, but beyond that, it's by your state. And again, good practice. And I know Southern Illinois, there's a lot of TB there in that rural segment of the state. That's the state that has Chicago and then the rest of the state. And so there's fair amount down there. Good question. We're good,
Hey,
Danny?
Kate, this is Mark. I got a quick question too that I got this week. We've got a provider-based clinic it's hospital. The clinic itself is in Georgia, and but all of the HR, all of the stuff that's on your checklist there is located in the main hospital that's about 45 minutes away. What do y'all do if you're in that situation? What should our rural health clinics do?
Yeah, we build that into our survey. We ask that long before we show up. And so we build it into the time. So sometimes it's a 45-minute drive, and we'll often come the day before and do the HR part and then go to do the physical plant. So we'll work it into this. I think that would depend on each state how they manage that. But it's quite acceptable that it's found, because it's very secure, and that they keep it in the mothership, if you will.
Thank you.
Good question. Oh, I was not quite finished with OIG. So the year is passed. So I don't know what your year is, but once a year, you've got to run everybody in your system through the OIG exclusion list. If you're billing Medicare, you cannot have anybody on that list in your employ. Okay. Okay, fire. So fire, we're always going to follow the fire safety rules of our state. We're going to have a fire extinguisher, at least one, for larger clinics more, and that's by your local regulations, dated and tagged and hanging on the wall somewhere in the clinic. Now, lighted exit signs are the safest way. You don't need floor plans posted on the wall or this kind of a sign. If I can see that exit sign from every exam room, as I come out of an exam room, turn left, turn right, can I see it? I'm fine. You need this if I can't see it. And I don't like this big thing because it takes me 30 seconds to figure out where I am on that thing. And we need to get out of there if we don't know your clinic and there is an emergency. So just to take note of that. Sometimes they're a little more trouble than they're worth, but just the lighted ones are the best. Okay. So pushing 2 years of a public health emergency and beyond a doubt, vials are the largest deficiency, and listen to me closely here, the largest reason to fail a survey. A single dose vial, which you all know has no preservative in it, is reason to fail your survey if it has a 28-day date on it. At that point, we don't know if that medication is safe or effective. We don't know if it's safe in 2 days, because that's why it's labeled single dose. Once it's opened, it goes in wherever you put your medications for trash, okay? So never should an open single dose vial be in the medication cabinet. Now, we've seen it and we're seeing it and seeing it. So I'm going to be 3 slides on this. Bear with me. I'm trying to fix this and I want everybody to hear this. Multi-dose vials, 28 days, right? Now, possibly a staff member does not know the difference, and we've seen this too between a single dose. I had one where I thought the practice manager was going to faint because the MA said, oh, I didn't know there was a difference. Well, that's really a problem. Possibly a certain drug has come to you. Maybe that's why we're seeing an increase in it as an MDV all along, and then during this pandemic when everything's upside down, maybe it came as an SDV and nobody noticed. So we've got to go back and train our staff. We've got to train everybody to pick up the vial, look at the drug, look at the dose, look at their expiration date, and look, is it single dose or multi-dose vial? Look at the top, has it been penetrated before? Those kinds of things if we're not taking the cap off. Okay, so really go back and train your staff. Save yourself this. First of all, we want to do safe and effective treatment for our patients, but we need to retrain our staff. Maybe we need to have a shelf for single dose and a shelf for multi-dose. Maybe you need to invest in some little red stickers for single dose vials. Lots of different ways, but separate them in the cabinet. Don't assume the staff knows this. I promise you that they don't all know it because we're citing it. So single dose vials, never dated. Multi-dose vials, 28 days, okay? So one clinic in the Great Northwest had this problem. And I was grateful that she shared this picture with me. For like 30 days, every vial that came out of that closet went in this little red bin. Nobody Nobody was permitted to put a vial back in the closet, and they found their culprit, and they fixed it. And they do that occasionally to make sure this is going well and that we're doing it right. So once and done, discard. Controlled substances, we're going to have a log for every dose of that testosterone that was given to each patient by name for every controlled substances. It's locked in a substantial cabinet. And watch out for the controlled that might be in your emergency box or in your refrigerator, because they also still need a log and they need to be secured. Your samples, we haven't, and so if Azalea is still listening, we haven't found an EMR that will pull the lot number up for a recall. So therefore, you're going to have a log. If your EMR will do it, that'd be great. But if you get a memo that Integra lot number X is damaged or ineffective or whatever, and you're going to call those patients and get the drugs back or tell them to stop taking it, whatever, you need to know who to call. And so by lot number, you're going to have a log on every sample you've given. Now, the one on the right came to us from the wonderful state of West Virginia, and years ago already, and they had so many samples, it took so much staff time to keep up with all that every month, looking for outdates, that they sticker them when they go in the closet. And so if we're now in the 12th month of the year and that's this black dot, then last month pink, they're out of there. Okay, so it works. It saves a lot of staff time. Watch your years on that. You don't want to be throwing away good stuff. Now, the CDC says there should be no medications in the door of a refrigerator. And so you see the one in the middle. If you're buying an expensive medication refrigerator, it has no shelves for that very reason. So nothing in the door. They also say that you should take up that dead air space with water bottles. Now, the reason they're labeled there is because we've had some state surveyors call that food. And so if you're concerned about, if we come, we know it's not there for food, but if you are concerned about that, then I'd label them and you leave them sit there. That's their purpose, to make the body of the refrigerator a more constant temperature. Now, the one on the right is a little refrigerator that you buy at Target or Walmart and you send your youngster off to college, right, for snacks. It is not acceptable for medications. That is, there are under-counter ones, and it would be in the manufacturer's write-up that says they're acceptable for meds. Most of them are not. That's because it's for just food. Okay. Oh, one thing on that. This is a great website for a lunch and learn for your staff to learn about handling refrigerated medications, vaccines in particular. And we know you're dealing with vaccines right now, right? Now, when you're doing your mock survey and you're walking through the clinic, you're going to open every door, every closet, every drawer, and anything that has a date, you're going to throw on a counter like this counter. They were all expired. And that took me about 30 pages of typing to write that one up. I'm not going to tell you what state it was in, doesn't matter, but they're all expired. Nobody thought to look at this kind of stuff. They were only looking at medications. But all these things have dates for a reason, and they do expire. So make sure you're checking all the rest of it. That little sharps container up there, if that's a patient care area, is not acceptable. That one I could probably get in my backpack if I was of a mind to have those needles. Instrument sterilization. If you're sterilizing in the clinic, we want to know your process. All right. If you're accepting instruments from the hospital, then you need to know their process, because we need to know with 100% certainty that we're handing a instrument to a provider to do a procedure that is sterile. You'd want a sterile one on your arm if we're suturing you up, right? And so we want to make sure of that. So we need to know, is the date right? Are they not using dates? Is that in a locked position, not just closed? All that. If we're sending them to the hospital in that container, is it one that'll close enough that we're not going to leak all over our trunks wherever you're transporting that? And what it is, at a time soak, all those things. I will say this, when we see a tabletop sterilizer, we do say, oh my, because about 98% of the time it's a citation. And here's what we do. And I want you to do this if you're using this method. Go back to your clinics and pull the manufacturer's instructions for use for that unit, because that's what we're going to do while we're with you. And we're going to read it together. And we're going to read how you sterilize instruments with that unit, and how you load log and spore test, all those things. And we'll see what whether that matches your process within the clinic. And we find that it does not. So it's a big concern that we're not sterilizing instruments properly in the rural health clinic. And believe me, it is a big concern. So save yourself some trouble and go do that today. Make sure you're giving that provider a sterile instrument. Now, disposables are obviously the easiest. They're also the most expensive, so we understand that. And the reason for this slide isn't so much that. It's the suture removal kit. When you open that suture removal kit, and you're just taking some stitches out, everybody knows those forceps and scissors are quite still usable. Put them in a drawer. Do not put them back in this container, because you're now representing them as sterile, even though that's been opened. And so that could be a possible problem for you. For the most part, this is all once and done, but you can save those. They're still good scissors and forceps.
Hey,
HIPAA.
Kate,
Yes?
we had a couple questions come in on that section, so I was going to ask you real
Sure.
quick. Do sample medications have to be behind locked doors or just out of patient reach as long as not controlled substance?
No. Go back to that one slide in your mind. All medications are secured within the clinic. Nothing is left unlocked.
Okay, and then specific to emergency preparedness, AEDs, are they required in the RHC?
They are not required unless your state would require. I'm kind of thinking California does, but I'm not positive about that. If anybody's listening from California, you could pipe in to Danny on that, but no, they're not required. We don't see them very often. We see them, but not that often. Good questions. Good
Okay,
question.
and then there's a Teresa that asked, can you have aerosols in the clinic?
You can have aerosols in the clinic, sure, absolutely can. Again, I wouldn't want them in the patient bathroom, under the sink. Kids get into those sorts of things. They're on the counter in the exam rooms, that's fine.
Okay, and those are the ones that I've gotten so far that relate to those types of items. Susan says Alabama requires an AED.
Oh, okay. Thanks, Susan. Alabama does. So many things. The higher level of compliance is going to win. So if your state, like right now, we have states with vaccine mandates. That's they still have to do that, even though the federal government is on hold. So you still have to live by that. So Alabama has to have that AED, and any other state, and that, like the TB, the states that require it. So there's a higher level of standard will trump all the time. HIPAA does not go away in a PHE. I'm going to tell you a real quick story about a clinic that had a high school football star, small town high school football star, came in, diagnosed with COVID, and then on Friday, one of the nurses noticed that there was a big party at that kid's house Friday night. Come on over to Joe's, Friday night. And she did not handle it properly. She posted on Facebook that he had COVID. That was not appropriate. And you all are rolling your eyes now, but this is the kind of stuff that happened. I know where her heart was. She didn't want the rest of the high school to come down with COVID, whoever wasn't going to go to that party, right? I understand that, but that is not acceptable. That should have been handled in a different way. So public health emergencies do not take away HIPAA. We're seeing some questionable things now about our vaccination status and whatnot, but still, it's still there. But in the clinics, for the most part, what we see are computers that don't time out quickly. So we walk into an exam room and there's still PHI up from the last patient, or a provider sets their laptop down and we can see it. Passwords and social media, I'll let you deal with those on your own policies on how often you change those. This is when you're doing your mock survey, you don't want to miss these two, but I put this in a different fashion here because we see this as a confusing issue. There are two types of chart review in a rural health clinic. Number one is physician oversight of your non-physician providers. So the MD or DO reviews X amount of charts for NP or PA, right, on a regular pattern. There's a log with patient names and it's signed by that MD or DO. Now, many states give a number or a percentage of patients that he must review those charts. If your state is silent, it's very important that you choose a number and you put it in your policy. And if you've got a nurse practitioner, Mary, and she's been doing it for 30 years and everybody loves her work, then do 10 a quarter. 5 a quarter would even be fine. Make sure you can show the surveyor a sheet of paper with the names of the 5 patients that he reviewed those charts last month and his signature, and then you'll be fine. This is true even in states where the NP has autonomy, and we see that, and they push back to us, but it's a federal regulation for medical director oversight. So make the number low. And that's the best advice I can give you on that. But make sure you can present to the surveyor for your survey the patients that were reviewed and by the number. Again, if it's your state has a number, you must live by that number. The second type of chart review is quality improvement. Now, this feeds into your biennial evaluation. So every 2 years, you have to do a review of your whole clinic and how it's functioned and how you've lived by your policies. We'll talk about that in a minute. You don't wait till 2 years from now or just before 2 years from now to review 50, 60 charts. That's not good. First of all, you wouldn't want to wait that long to see a problem. You know, we really think everybody should evaluate every year. The federal government went to 2. It's one of the things that surprised me because who doesn't look at their business every year? But again, it's only required every 2. So we like something like 10 charts a quarter. And this is a review for completeness. We're looking at the chart, at the file, the electronic file, to make sure all the elements of a complete file are in there. We've got a consent. We've called out, patients have been notified of labs, the charts are signed off, all those things. And so keep that log for the 10 for last quarter, let's say, throw it in a folder, and then when you get to your biennial, you might have 70, 80 files. Don't forget to add a closed record on occasion. The government doesn't give us a number on how many, so every time maybe you do it, you do 1, and you'll be fine. Identify it. We find that's true too. Oh, we know we did closed records, but there's no way to tell it, so make sure it's identified in your log. Now, staff responsibilities. The PA and the NP practice in accordance with your policies. That's why they sign off on them. They participate with the physician in that periodic review of records, and they sign that policy binder at least every 2 years. So we're going to see 3 names that are going to come up on that policy binder. The physician does the exact opposite. He works with the NP or PA in developing, executing, and reviewing those policies and reviews the patient records. So what does your policy say about how many charts per month per quarter, as we just discussed? At least one NP or PA must be an employee of the clinic. So you're doing your mock survey, you're going to look for that W-4 of that one. And most of you, they're employed, and it's not a problem. But if that's not the case, you must make sure that one of them is an employee. We do hope that changes with the Modernization Act, but it's not been passed yet. Remember this. The provider must be in the clinic before you can do anything in the back. They can come in out of the rain and sit in the waiting room all day. They can come in and check on bills. They cannot come in and get blood work done, weights or blood pressures before there's a provider in the building. CMS is very firm on that. I know it's not true when you go to Quest or somewhere for blood work, but it is true in a rural health clinic. And then lastly, the NPPA or midwife is available to furnish patient care services at least 50% of the time the rural health clinic operates. Right now, that one is on waiver. So if you've had to pull your NP, or she's ill, or she's had to go to the hospital for a surge, and she doesn't cover 50% of your hours, you're good. Document it. So have a little log and say the week of December the 13th, next week, she won't be there 50% of the hours. She's going to be working at the hospital. Just keep a little log so that if it comes to question you, you know what went on. It is covered by the waiver. She does not have to be there 50% of the time until the PHE ends. Now, this is the slide that really we see this very often, especially during COVID, because we've missed some review stuff. There is a log, a signing sheet in your policy binder, and it can be electronic, and it's signed by 3 people, an MD or DO, the NP or PA, and at least one person who's not a member of the clinic staff. So they don't work there. They work for provider-based clinics. It's quite easy. It's somebody from the hospital, and that works quite well. But for independents, you have to find somebody to sign off on your policy book. It could be the local pharmacist. It's someone that has some knowledge of what you do, not as somebody totally unfamiliar with medical work. But 3 signatures, never more than 2 years old. Okay. This is coming up a lot lately. As you're doing your mock survey and you have a lot of specialists in your clinic, take a month and add the number of visits that were provided by your primary care specialists, your primary care providers, and then the number of visits that were provided by all the specialists, the mental health folks, the orthopedics, dermatology, anybody else that's not in primary care. Remember, primary care includes primary care, women's and OBGYN, and pediatrics. So that's all good. That's got to be 51% of the services that you offer in the clinic. There are people that do get audited. Most time it comes up with something like Suboxone when you tend to get overrun, and those are mental health visits. And so be careful about that. We want the specialists. We need the specialists in rural for sure, but just be careful of that. So there are 6 tests required in every rural health clinic. This is another one that is in the change for the Medicare Modernization Act, and we cannot wait for this one to go away for the simple reason that you should have what tests you need to do right now. But here's what we do expect with this. You can get me the results of all 6 of those tests today for a patient standing in your clinic. That's the question you need to answer. I don't care if you ever do one, but you must have the ability to do one today. That means particularly for hemoglobin or hematocrit, you've got the little machine, whatever you have, a HemaQ or another type, you've got controls that are in date, and you could do one if you had to do it. We know that you don't do it that way. Everybody orders a CBC or a complete panel. So we understand that, but the law still says you have to have the ability to do it. The one on stools, remember this, it's the one where you drop the reagent on the card in the clinic. It's not one you send out. You don't want to get caught on that. And hopefully that'll go away with the Modernization Act as well. But make sure you have the ability to do all 6. You have all the supplies are in date, and that your CLIA is accurate. You check that CLIA, make sure it's in date. They do expire, and has the correct name, address, lab director. CLIA is mostly tied to address. So if the name is off or the lab director is off, it's usually not a problem, but that address is what's really, really important, okay? So that's the lab part. Now you're gonna sit down with your team and look at your policy binder. Do we have a description of the services that we offer in our policy binder? And that's kind of like your mission statement. So we offer primary care health from birth to death. And we refer, and you throw some things there that you always refer: surgery, mammograms, colonoscopies. You know, we don't do those in a rural health clinic. So those are things that completes that standard without a problem. The guidelines for medical management of health problems is generally covered in the collaborative agreement. Beyond that, what is the reference that your NPs or PAs use to look something up? We're hearing up to date about 95% of the time. Make sure it's in the policy so that the person, the surveyor might ask, you know, what do you use for your reference? They'll say up to date, and there it is in the policy, and we're good. Why is it in the policy? Because the medical director has signed off on that policy and agrees that that's a good resource for her. It's not Mark's primary care medicine, which we wouldn't want to read. You know, it's something like that. Okay, so that's why it's there. The maintenance of health records, that's pretty easy for your provider-based clinics. We've got somebody at the hospital who's in charge of our records. We've got to have somebody in the clinic who's got that in their job description. Next is your rules for storage, handling, administration of drugs and biologicals. That's a hefty policy because there's a lot of elements. You'll see that on your checklist on what should be in there. Don't miss what happens to refrigerated medicines in a power outage. And you should have a policy on multi-dose and single-dose vials to keep everybody straight. And again, these policies are reviewed at least every 2 years by that threesome, the medical director, NP or PA, and that outside person. So we're required in a rural health clinic to have emergency services. This has been a delightful change. So we didn't have that list of things that we were always fussing over, antibiotics and snake bite venom and all those. Now we can have a list of drugs that your medical director and your NPs and PAs have decided are what we need at that street corner. They're practicing at that street corner for a while. They know what we need. And we see very, very much of a variance in this. If we have a rural health clinic in the building of the hospital, why have a robust emergency box to keep track of? Have what you think you need, and probably an EpiPen, maybe a baby aspirin, whatever. And then the crash cart from the ED is right down the hall. But if you're 20 miles down the road, we need to have a robust box that's going to use those drugs until 911 arrives, until emergency services arrive. But the point is, the list of drugs that the physician and the NPs have decided is what you need in your clinic is in the policy. Again, for that very same reason, because it documents when he signs off on it that he agrees that that's what we have in that clinic. The emergency box should be portable. We grab it and run. Hopefully you're grabbing oxygen and tubing and the same, and you've got you've got an emergency dealt with. Maybe your policy also says we're calling 911, depending on what the issue is. All right, just check that box for outdates when we're checking that once a month cycle through the clinic. Now, when you're doing that QI to feed into your biennial review, these are the elements at 491.10, which is called a complete chart. So across the row, that's exactly what it says at 491.10. So you want to make sure, now you've trained someone to do this. This is a person, a clerk, a tech. You can train someone to do this, to open up whatever your number is, let's say it's 10 records, and go across the row and make sure we've done everything. Don't miss written consent to treat. We find that you forget to scan them in. You get a paper and it doesn't all get scanned in. We come from survey and 3 of the 10 don't have a consent. And so that's a deficiency, of course. If 10 of 10 don't have a consent, that's a big deficiency. 3 of 10 is a little deficiency. The other one is labs and diagnostics, and that is that they weren't called out to the patient. So if you have a high A1C, there should be a note in the chart that the patient was notified and what we're doing about it. And then your policy is going to say how quickly your charts have to be signed off. Is it 24, 48 hours? The longest I've ever heard is 72 hours, but that's by your policy. All right, so make sure we've got that covered. That's your review that's feeding into your biennial. So we're checking our files for completeness. Now, many people take a list like this and add billing and coding, and they can do it all at once and make sure we're not upcoding, undercoding, in a regular fashion, so we don't wait till we have a problem or miss out on some revenue before it's too late. So your biennial is your review of your program every 2 years. I'm aware of only one state that still has it every year, and you know who you are. That must include a review of the utilization of your services, including at least the number of your patients served, your volume of services, a representative sample of your closed and active charts, and your policies. Those are the 3 elements. Please go back today and check the date of your last biennial, because we're finding with COVID, people got pretty busy and pretty off track and they missed it. And that is a failed survey. We don't want a failed survey. We don't want anybody to fail. So that's just because it was done in 19, which means it should have been done in 21 and we didn't do it. And believe me, it's happened 3 or 4 times. So please go look at your date. And if you haven't done it, get it done. Get her done, because that's if you don't do a biennial, it's automatic failed survey. You don't need that. You don't want to put yourself at risk ever for losing that billing number, which is why you're going to do your own mock surveys and stay company ready all the time. So why are you doing a biennial? To make sure your services were appropriate, that you followed your policies. You will find that there's going to be things in there you've changed the policy on that. We don't do it that way anymore. So you need to go back and change your policy and then evaluate what you found. It's like emergency preparedness. If we don't evaluate and do a paragraph on what we found and what we're doing about it, we haven't done a complete biennial evaluation. Now, you can do it yourself. You can hire Mark to do it and some others, and they do a phenomenal job of doing these biennial evaluations. Take that stress off yourself, and they won't let you go past 2 years, I promise. Now, this is a big subject. We'll do the best we can. I want to save more time for questions here. Just hit the highlights here. The new part of EP is that you must include emerging infectious diseases as one of your hazards, okay? So make sure you add that in. We're living it, so it's just going to be a possibility for everybody, which makes sense. Your communication plan, every person that works in the clinic needs to have their name and phone number in that plan, and then all local, regional, state, and federal emergency staff by phone number. You must address volunteers. The simplest thing to do is to say, Mark's clinic has made the decision not to utilize volunteers. We will accept that, and we've yet to hear a state that won't accept that. But if you don't address it, you got to think of your surveyors just like your checklist. They have to check every box, and you didn't talk about volunteers. So either way, whether you have them or don't have them, so you didn't address it, so you didn't address the regulation. We understand that came from hospitals. We don't see volunteers in clinics, so you have to address it. Again, how your refrigerated medications are handled in a power outage, don't miss that. And training, so you have to train your staff on your emergency preparedness every 2 years. So that's a sit-down training of your policies. And then you have a log with all their names and a date and what we talked about, EP, obviously. Okay, that's the training, that's not the testing. Testing is a full-scale exercise or event every other year. Now, you've had a full-scale exercise 2 years in a row called 2 events. Last year was COVID when it emerged, if you will, in 2020 with signs on doors and social distancing and getting enough PPE and getting hand sanitizers. This year, it's vaccines and testing. Very different, two different events, and you can use them 2 years in a row because they happened just like that. And so make sure that you analyze. You see, analyze is highlighted because we see that missed. Oh, we've got COVID as our exercise this year. Okay, show me. Show me what you did, what you didn't do, what you learned. You've got to write it up, okay? And make sure. Now, the other years, the odd years, then you can do a tabletop exercise. So this is the CMS AAR, after action report. Some people call it a hot wash. The form itself is pretty wonky, but it does call out the right elements. So you're going to put a plan together. You're going to say this event began, and I put 20 and 21 because you can use it 2 separate write-ups for 1 year and then the next year, okay? At your clinic, your governor declared your state of emergency on whatever date last March or March of 2020. This report is your analysis of that event. The purpose of this analysis is to evaluate our program. What were the strengths? Now, these are just ideas. You're going to edit this to your idea, but steal this, please. What areas did we need improvement in? What were our successes? What staff training did we do? You all did a great job of jumping into telehealth. That was amazing, pretty quick. And so make sure you're doing your analysis. And then the new guidance for Appendix Z, your exercise, if it's not an event, must be one of the list of your HVA. So if you're not in a tornado area, like I'm not, we don't have them in Pennsylvania. Maybe 40 years ago or something, we had one. Then you wouldn't do an exercise on tornado here. It wouldn't count. And that if your surveyor is going to hold you to that. So, okay, and you have to add the EID. You have to always be sure you're in compliance with your state. They don't want you to test the same thing year after year when you're doing exercises. An event is an event, and it happens, so we're good. Volunteers I already hit, and it just got a new paragraph in there about waivers, policies, and procedures in the emergency preparedness plan describing your role in providing care at alternate sites under an 1135 waiver. So you might want to think about adding that one in. We're just rolling into this slowly. I know it became effective in April, but we are in the middle of a pandemic. So now we're back to ending our mock survey. Can your staff articulate what they're responsible for? Mark asked me whether this was a typo here. What do you have to do to get fired here? The reason that's there is that you need to have standards of conduct. What is you to expect of your staff? Perhaps that nurse who posted that story about that youngster on Facebook would get fired under normal circumstances. That is a HIPAA violation. Did your staff know the answer? What can they post? What can't they post? What can they have? Purple hair, green hair, whatever. You have standards in your clinic and your staff should know what they are. And so when we ask that question, we know you've been trained. Okay, what do you have to do to evacuate the clinic? Have we had a fire drill? Do we know the protocol for that? Really important. That's the basic emergency preparedness that we've been doing always. And then your staff should be prepared to answer questions related to their job again and know where to look for other things. So share that wealth. So your surveys are always unannounced. The managers should share their knowledge. Most take 6 to 9 hours, at least they do for us, and probably for Quad A as well. If multiple clinics are surveyed at the same time, you'll know on the second one that's going to happen tomorrow. That's a no-brainer. What can I tell you? That's the way it goes. And then having easy access to policies. They can be electronic, no problem. Just make sure we can see them all. And then the exit interview tells you, what the findings were for the day. And then you can get started on your plan if you have to do plan of correction right away. Now, real quick, I'm not going to go through this, but I wanted you to have what the law says regards the vaccine mandate. You know that this is not surveyable at the moment unless your state has a vaccine mandate, and it may look different than the 491(8)D, which is our new law. We all have to just wait and see if the federal government wins an appeal on this, and they are going to appeal that or have appealed that. But I I have to tell you, if they win on appeal, I feel this will turn around quickly. So you should be working on this. You have the NARC policy samples as a handout today. Please get working on your policies. Who's vaccinated, who isn't. Start working on this. There is no test out option. You've got to know that. That was in OSHA. That is not in 491.8. It's vaccination or religious or medical exemption. Okay, and so I'm not going to go through this and read this to you, but I did want you to have it. Okay, and so I'll skip through that. The only thing I wanted to say was, and I missed it, but it's a process for preventing the spread of COVID. You will need to be doing that. That's long before this. We're looking at that to see what you're doing at the clinic, what precautions you're taking to keep your staff and your patients safe with the COVID as it keeps on rolling. Okay. Phew. What kind of questions do we have?
All right. Thank you for that. Most of these deal with the mock inspection. Brittany asked, for the sharp containers, we are having a hard time getting the ones that hang on the walls. We have some on the countertops. Do you recommend that we take them in for the injection and then remove them each time?
Well, I would say that would be good practice. And I would also document what your issues are to try and get those lockable mounted sharps containers. We can't make it up if you can't get it. You know what I'm saying? It's like something on back order kind of thing. But I document that how I'd ordered them.
Perfect. Is the chart review for only NP and PAs, or do you include other physicians that are in the practice?
Well, some of our biggest offenders are MDs. So I would say I do a random sampling of everybody that works there. Now, so that's great that you said that, because I fell right into the trap of the two types of chart review. For QI, it's everybody. For physician oversight, it's only NPs and PAs.
Okay. How many NPs and PAs can a physician be over?
That's very state specific. So you'd have to check with your nursing board and your medical board on that. I mean, I hear 4, but again, that's definitely by state.
Okay. Does the provider have to be present within the RHC before any services can be provided? Or if you are in the same building as your ER, will that be sufficient?
So, yeah, yeah. They have to be at let's say the clinic is its own entity. That's the way the law is written. That sounds like we're trying to find a little workaround. I would say the provider should be in the clinic. Yes. That'd be the CMS answer.
Perfect. Are Suboxone visits performed by an FNP considered a mental health visit, or only if it is performed by a PNP?
Yeah, that is I can't answer that one, because we had a clinic that had to move the physician doing the Suboxone because they went over 51%, and it was a primary care physician. So I am actually in a research mode on that very subject. That is a great question. I do not have the answer to that at the moment.
Okay. Our internal mock surveyor said the red trash cans do not have to have bio stickers because they are red. Is that the case?
Well, that's interesting. We require the bio sticker, so that may be the case, and I'm going to actually look that one up and get back to Mark on that one.
Okay.
That's a good. I've never been asked that one. Learn something new. I'll check that out.
Okay. Does the RHC have to have a medication refrigerator?
Well, not if you don't have any refrigerated medications, certainly not. But just don't use your food refrigerator. No, I wouldn't say it's a requirement, but most of us have medications in there.
Okay. This deals with the 51%. Is a pediatrician considered a specialist, and the patient encounters count toward the 51% that an RHC cannot go over?
No, pediatrician is not a specialist. He's a primary care.
Okay. Jody said she caught the end of this section. For required tests, can the hemoglobin and hematocrit be a blood draw?
Nope, because you can't get the result right now.
And then we gather a lot of the required information for an inspection in our RHC binder each year. This has become hard to keep up with. I like that all the info is in one place, but I am wondering if there is an easier way to do this.
Well, it's the easier way is quarterly to be checking it. There's so many moving parts with rural. Yeah, I don't have an answer for that as an easier way. It's just constant checking and some tags to show something that's going to change, and you have to get back in there and fix it.
Yeah, Kate, I had asked Patty Harper to be here to talk about Inquidocs, because I thought that would be a good thing, because Inquidocs does have the evidence binder and the policies and procedures, and it's all electronic. And
right.
So, but Patty's dealing with her family situation right now. But we're going to get around to having a webinar where we're going to get Patty on and Jeff and talk about how you guys can use Inquidocs to create that evidence binder that's company ready at all times. And I'm not going to say it's going to be perfectly easy, but it will be a great system to keep you guys compliant at all times.
Let me comment on that, because our surveyors love Inquidocs because it is a subscription service on the internet for your policies, and they can tell who goes in there and reads it, how long they read it. They can tell how long our surveyors read the policy, and who's not read it, and they can send emails to that, and they update things constantly. It's phenomenal. I will do a shameless plug for that system because it keeps everybody on track.
Does the medical director need to review counseling charts for the LPCC or LCSW like they do PAs and NPs?
That would be by their license. We would have to check that for their license.
Okay. If policies are electronic, how should they be included in the biennial evaluation?
Well, you don't include them in the biennial. You review them and document that you've reviewed all your policies every 2 years. They're not physically in the biennial. They're just reviewed every 2 years. Good question. And it's that signature page with those 3 signatures that we look for to document that.
Kate, I had a question real quick. I got one this morning, and I get this all the time, got a clinic and they're asking about their inpatient. It says you have to have access to inpatient services. Healthcare's changed in the 40 years that I've been dealing with it. A lot of these clinics don't have a whole lot of direct access to inpatient facilities, especially my brain's not working, but they don't have access to it like they used to in the old days when you have courtesy privileges and all this sort of stuff. What do they need to do to show compliance with that piece of regulation?
Right. They have to show evidence that their patients were accepted for care at a hospital. It's that simple. So we will go to the EMR. They'll be able to tell us who's in the hospital. And if we see that, we're good. Does not need to be in writing, just evidence.
Okay, good deal.
Couple more. Can the medical director have to, I think they meant, does the medical director have to be on site, and can one medical director be the director over more than one RHC?
Okay, so I was waiting for that question because it's a very common. Now, I'm going to say this. The compliance team feels that unless the state requires his physical presence, that all the things in 491.8 he can do electronically. Okay, so we have many that never set foot in the building, and all those things it's a modern age. We can do it all electronically. Now, there are some states that still require his presence, X number of amount. If you are concerned about that, then have him come once a year and document the heck out of it. That day that he came, he saw 4 patients, he reviewed some charts, he reviewed some policies, and document it, and you'd be good. Because if they do require it there, and federally, there's no number, there's no amount. Okay. We have many, many clinics owned and operated by NPs, and they do just fine with the electronic supervision.
Yeah, Kate, there's a lot of states where in their scope of practice for supervision for the nurse practitioners and PAs, there's a piece in there that says every quarter the physician has to physically be on site. So you gotta watch your state regulations as well, and to make sure you read that. There also is something in the federal rules that says, and I don't necessarily agree with this, I think it may be an interpretive guidelines. It says that the medical director should treat at least 1 patient per year. That's what Shante Carter tells us at the CMS office there. I think for the most part, everybody's just ignored that because it seems ridiculous to me, but that's.
Yeah, it says provide medical services. It doesn't say one patient. And so we think that he can provide medical services electronically through his NP.
Yeah, that's what Shantae was saying. We had to have a visit. I was like, okay, we'll bring somebody in and do a visit with it. We'll bring our medical director in and do a visit, but it doesn't make any sense to me. So okay.
Well, it doesn't. But I say, if you're concerned about that, then have them come in. Yeah.
Okay. Let's see. We got it. Do you have a few more minutes, Kate?
I do.
think I've got like 2 more. Okay. Is there any standard regarding infection prevention, specific place of keeping specimen fridge and medication fridge?
Well, you never want to put your specimens in with your medications. And we have had issues where they have had to put the specimens on the bottom shelf. We don't want specimens leaking, should they leak, from the top onto medications. That would be number one. But the ideal, of course, is complete separation. We don't want urine in the med refrigerator, and we don't want any food in the med refrigerator or in the specimen refrigerator.
Perfect. Are you required to have pharmacy dispensing license for your practice if you do not have a pharmacy within your practice?
No, that would be a state thing. I've never heard that anywhere. No.
Yeah. Okay.
I think there was
is that all of them?
There was one other one that's kind of goes back to HR. Is it suggested or mandatory for background checks?
There are states that require background checks. That's why I said, if your state requires it or it's in your policy, and it's good practice, do you really want to hire? What happens in rural? We know this person forever. Everybody in town knows her, so they don't do one. But they only get in trouble with that if it's the state requirement or they have it in their policy that we do background checks. Again, it's good practice to do background checks.
Yeah. And you definitely want to do the OIG exclusion, Medicare exclusion. You want to check that before you make an offer to anybody. And and then Kate, how often should they check that? I hear 1 month, and I hear every month, and then I hear every year. I've been telling people every year because that just seems reasonable.
Every year is the federal. There are a couple states, and I can't name them at the moment, who have gone to monthly, and that would be probably where there's a fair amount of fraud. So here's what happens, and we had this incident. Someone in a clinic, when they came on board with us, they never did OIG, and they found one of their people was there on that list. Everybody had a heart attack, and what happened? She was 15 years ago, she worked at a DME, and they got in a little bit of trouble, and it doesn't automatically come off. You have to write a letter to get your name off the list. And so it's something to be wary of, for sure. But yearly is good. If they have a job with you, but they're working over somewhere else part-time, they could get on that list and you wouldn't know. So you don't have to keep at it all the time, but yearly is generally good. We haven't had any problem, just the one time.
Yeah.
And she came off, so.
Yeah, and then I'll make one reminder too. I know because last year I've been doing this for 35 years now. The first time ever we had a initial inspection, we had one of our clinics fail the initial inspection, and the only deficiency they had was single dose vial and multi-dose vials. I think, Kate, I've heard your speeches before where I think last year you had 22 different clinics that failed their inspection. CMS was requiring that to be a condition level deficiency. That's an automatic failure. So keep your single dose and your multi-dose vials separated. Make sure you do an in-service with your MAs, that they know that things are coming in different things that used to be multi-dose are now single dose, and things that were single dose are now multi-dose. So you want to make sure they separate that and understand that. Is that right? Is that what you would say, Kate?
Absolutely right. So let me tell you a quick story for a minute. This is about 5 years ago now. A surveyor, we have a 911 system. When they're out in the field, they can call 3 of 4 different people if they have an issue. And he called and he said, I have a single dose vial with a 28-day date on it. And he hadn't mentioned it to anybody yet. And I said, this is before CMS spoke up about this. And I said, go around and ask everybody all day long about that. And everybody knew it was egregious, and oh my goodness, it must have been a mistake. And everybody knew the process. And they had like 50 vials in this clinic. So it was one of 50. And so I said, well, write it as a standard level deficiency. So that proves to us in their plan of correction that they went back and taught it again, which is what I wanted to see. I wanted to know they went back and taught it just in case. And so standard level. 3 months later, CMS, I get a letter from CMS overturning our survey, making it condition level. We had to put somebody on a plane quickly because I felt so badly and get it out there. And of course they passed survey after that because they had made their change. So that's where that came from. Believe me, we did not make that up. There's no degree here. It's called 1. So very important.
Yeah.
Very important.
And I think what Kate said about program evaluations and reviewing everything every 2 years, this is 30-something pages of deficiencies I got on my desk the other day from somebody that didn't do that. There's like 3 condition level deficiencies of no emergency preparedness. I always tell people the easiest thing in the world to do is pass this initial inspection, because you know companies coming over. Christmas is coming, you know they're coming, but in the middle of the summer, when you're not expecting anybody, you want to have your clinic ready for them to show up as well. And if you don't, you're going to get page after page after page. So, Kate, thank you for doing this. I think everybody was very excited. They wanted you to do this, and you did it, and we appreciate you very much for that. And so thank you for everything. You got any last words before we close her down?
We appreciate you and Danny so much as well. We love working with you in your clinics, and I want to wish you all a Merry Christmas and a healthy and happy New Year. Very, very much so this year. You take care.
Okay. Happy holidays, everybody. Thank you. Bye, everybody.
Bye-bye.